All right, guys. Last one.
Awesome. I hope you have that on video.
Okay, so here's the deal. We want to finish up this piece, talking a little bit about pelvic floor. And as I said last week, we're not going to really do reproductive system just because we only have one option downstairs, and so we'll use it for the point of view of looking at the formation of inguinal ligament, the relationship to the abdominal muscles, but not really do dissections of the spermatic cord. So try to identify cremaster muscles, os deferens, pempeniform plexus, testicular artery, parts of the testicle, or anything like that. Okay, so we just use it as really kind of that. On Tuesday afternoon, I got the one cadaver opened up. I haven't done anything with it beyond that. So right now, it's just the ability to look at it and see the greater omentum, the relationship to the stomach. So this afternoon, the plan will be to kind of work on that, work between the two and see which one I can get a better view of like the celiac trunk, superior mesenteric artery, inferior mesenteric artery. Look at the kidneys, the ureter, decide whether I need to kind of ligate and cut the sigmoid colon, the rectum, pull it out of there just to get a better sense of the ureters going into the bladder. Okay, specific to the fact that they're both, or all three of them are males, but the two that are supine that would have that access to, I'm not going to open them up to the point where we can see the prostate gland. Hopefully, I can get enough. So I feel like I'm losing it. But hopefully with that is be able to get to at least a sense that we can get down to this level, looking at it from the inside. So we can see the relationship, not so much of kind of the sphincter piece, but really get a sense of the pelvic diaphragm on the inside, so that we can see the relationship of the muscles to the pieces that we've already talked about, piriformis, obturator, internus piece of that. And with any luck at all, what that will allow me to do is be able to look at sacral plexus. Okay, so you can get a good sense of how lumbar plexus, even though it's pretty much obscured, because the formation, the combining of anterior and posterior divisions of those ventral rami actually takes place kind of right inside psoas major, so it's kind of hard to see. And all you end up seeing is the end product, which is the femoral nerve and the obturator nerve. And we're not going to, like before, we're not going to get too bogged down in all the other little nerves that are coming off of that. Same thing will go with the sacral plexus and the pelvis, to be able to see, can we see at least the branching of common iliac to external, internal iliac, follow external iliac, continuity to the femoral artery, internal iliac and its relationship to piriformis. Can we then see superior, inferior gluteal nerves and vessels from the inside, specific to what we had as kind of a relationship of how they emerged above and below piriformis on the external side of that. So try to make some sort of relationship between that, and in doing that, find the structures that are easily taggable for the lab exam on Monday. Okay? Now, specific to taggability, those kinds of things. So tomorrow, I just I don't have anything scheduled, but I certainly am going to spend time in the lab tomorrow to try to make sure things are as clean as possible. And then Saturday afternoon, I will be probably 3:30ish. I will also be in the lab, not because I have just this need to be there, but my mother-in-law and my wife are going to some little old ladies watch the Kentucky Derby thing down on 32nd and Federal, and I figured I'll just come up here and make sure I have all my ducks in a row on Saturday afternoon so that Monday morning I can do as much tagging and get as much stuff taken care of over the weekend that I don't have to worry about doing it on Monday morning, okay? So if you guys are around and wanna come in on either tomorrow sometime, and if I'm not down there and you guys wanna come in and I'm up in my office and you want me to come down to the lab, just let me know. Because right now I have nothing on the schedule. My grades are in for the DPTs. That's done. I have nothing left to do with them for one day. Only one day. So again, tomorrow's a free day for me. If you guys are here and you want access to the lab and you want help in the lab, or you want something else, please come get me. I'll just be in my office. And again, Saturday afternoon, those little old ladies start drinking mint juleps at 3 o'clock. So, have you guys ever had a mint julep? Those are awesome. I mean, outside of the fact they're so sickeningly sweet, how better way to drink Jack Daniels than with mint and powdered sugar? I mean, really. Out of a silver cup. Out of a silver cup. So, I've never had one until I used to ride horses with a bunch of guys. We used to have this really decadent summer riding thing in the Bighorn Mountains of Wyoming. It was just guys, no gals, just guys. And one afternoon, it was usually the Saturday afternoon when we were done, because we'd just pack up and go leave on Sunday morning, because we would have this mint julep party. And they'd start infusing the Jack Daniels and the water with mint 3 days before. And I mean, those things go down like soap pop. You don't even know there's half of it's Jack Daniels in there. So, but it's good. Not to mention the rest of the riding, the 3 days of prime rib, shrimp, prime rib sandwiches, hot water showers in the morning in the mountains. It was a great time. But unfortunately, all the older board members started to retire and give up, and so now we no longer do it. But it was a good time. So.
When will you have our grades for our exams?
That will be the first thing I need to do tomorrow, okay? So today I can't do it because of the lab, but be the first thing I work on tomorrow morning, okay? Yes?
Do you want us to write a letter?
So that's what Suzanne and I were talking about when we were drinking coffee in front of the coffee pot. So in the syllabus, and I have to admit that I didn't pay a lot of attention to that, but I copied the syllabus. You know, I got a template from Dr. Yelia Creighton that said, okay, this, and in there is the specific thing is we want you to write a letter to the family. And I think that's, you know, in retrospect, that's a really good idea. Now, how do you write a letter to a family that you don't know that you don't know about? So we were thinking about it and said, okay, maybe, you know, I put my foot in my mouth a little bit by keeping that in there, but I think it's a really good idea that in some way, and this doesn't have to be class-wise, it can be individual-wise, it can be part of the class, is that if you would like, we can, meet, I can talk to Father Dumpy, who is he's part of, have you guys met Father Dumpy? So, you know. So, I mean, we can have a discussion with him. As for the actual letter and where it might go or what it might do, the State Anatomical Board had its annual memorialization of the gifts back in April. So, we didn't meet that. So if we wanted to do something individually, each one of you, individually as a group, or just in some way have a way to thank the families, then I think that that's fine. At this point, you know, while it seems very explicit in the syllabus, I don't want at this point it to become kind of a last minute thing put together, because I think we lose the idea of respect by doing that. But if you guys as a group or as individuals want to write a letter thanking the family, and again, it has to be kind of this open-ended thing because you don't really know who they are or what they are, but you can thank them for the gift of allowing you to learn from that gift. And at that point, I can give those to the state board, and the state can then give them to the families of the three individuals who we have downstairs. Beyond that, I think going forward, and that's kind of what Suzanne and I were talking about, is how do we do this differently, or do we do it differently, or do I make it an effort to make sure that I find the exact date and we have an opportunity to attend the memorialization at the State Anatomical Board in April, which is when it is. Now, the other side to that is how do we, or do we incorporate the other programs that use cadavers here on campus? The PT program has 15 cadavers, and they have the same question, but they have that question when they're using the cadavers. And then they're done, they have a Christmas break, they come back, and they take neuro, and they take other things, they take physiology, and all of a sudden, their thoughts on thanks, their thoughts on the gift become very, very minimalized and in the past. And so, you know, is it something that we as a group at Regis, from PTs, the OTs, the undergrads, biomedical sciences piece, do we come up with something individualized that we can then incorporate all the programs utilizing cadavers here on campus, using Father Dirk, maybe somebody from the State Anatomical Board, whatever, somebody from our ethics program, and come up with something that might be a bit more meaningful, specific to Regis educational programs, and can there be some sort of continuation of that or extension of that, then gets sent to the State Anatomical Board and used at the memorialization service. But again, because we're displaced, we're kind of out of the loop of that, other than me knowing that it's there, okay? So I think at this point, I would ask you, if you want to do something individually and write a letter and give it to me, and I can make sure that the state board gets it and it can be forwarded to the families. If you want to do something as a group, if you want to do something in your own heart and have it go no farther than that at this point, I think that's great, okay? I have to admit, and I don't know whether it's an admission of out of guilt, out of whatever, I don't know. I do think about it, But after 30 years of looking at hundreds of cadavers, I no longer, and this gets to my own personal beliefs, that the people aren't there anymore, okay? And I see it as a tool. I see these cadavers as a tool. I do understand the gift part of that because as a graduate student, I met with families, I embalmed cadavers. I did all of that. So I understand that. But again, 30 years down the line, I don't want to think that I'm jaded, but I do want, but having seen so many cadavers and really on the more personal side, having family members pass away, friends pass away, I want to think of them as their soul is no longer there. The gift is there. It's a tangible gift at that point. The intangibleness of that, the idea of the gift itself and the decision to make that was made when they were living, functioning, thinking, empathetic, sympathetic, compassionate individuals. And what's in front of us at this time, what's in front of me at this time, and I'm going to put it on you guys, what's in front of me at this time now is a tool that I can use to hopefully teach you anatomy that you can use down the line. Okay? So that's my own personal belief, both on the spiritual side, the soul side of that, versus what you guys have in front of you. I don't want that to jade your thoughts and what you want to think about it, and that's why I think at this point, at this late date, without having a bigger conversation, I think I would like to leave it to you as individuals, or if you want to do it as a group, then let me know. But I will make sure that I get the letters or any sort of thing that you want me to transfer to the families. I will get them to the families. Okay? And I hope that's okay with you guys. If it's not, you can let me know. Okay? On the other side of it, I almost want to go back and say, why did you smoke? Especially to the one, the family of the one. It's like, why did you smoke? I know when my father-in-law was in the service he entered World War II at 17 years of age. He didn't smoke before he left, but certainly that was a piece of being in the military in World War II, is everybody smoked. And, as a drug, nicotine is great. It's a great drug. Ramps you up, makes you feel good, but the other pieces of everything that's in tobacco aren't so great for you. So you want to go back and make choices, retroactively. It's pretty difficult to do. So beyond that, so let's finish this up. Then this afternoon, and we don't have to, we can go in earlier if you want. I have a couple things I got to do after class this afternoon to help my wife out. So if I can get out of here a little bit earlier, it'll be great. So going in early is not a big deal for me. I have my chicken sandwich. I'm good to go. 5 minutes and a cup of coffee. Good for another 4 hours. So. But anyway, this is kind of where we ended the other day. So what I want you to think about, when we look at these cadavers today, tomorrow, Saturday, Sunday, whatever, is I want you to understand this relationship, this external relationship of things that we've already seen. Piriformis obturator internus tendons. If you can sit there and in your mind, sit there and layer things back on top of that, around obturator internus tendon, we can have off this ischial spine, we can have superior gemellus off the angle of the lesser sciatic notch, we can have inferior gemellus coming out together. With respect to piriformis, coming out above and below it, we have nerves and vessels, superior and inferior gluteal nerves and vessels. And then everything superior to this, and from deep to superficial, is gluteus minimus, medius, and maximus. And then here's the cut part of the sacrotuberous ligament. So again, we have that attachment of those inferiormost fibers of gluteus maximus, okay? When we look at it internally, it's a little bit more difficult to be able to say, okay, here I have my piriformis muscle. So here's the anterior wall, anterior part of the sacrum, and coming off of that, inferior to this level though, is the attachment of piriformis, and it goes towards the lateral side, kind of here, going towards that greater sciatic notch. It kind of underlies this tendinous arch as it starts to exit. So again, this tendinous arch is really a fascial separation of those pelvic floor muscles from the muscles of the lower extremity. And while they don't form are not going to form a very stable attachment, should that be part of their listed attachment, because if I can get it out of there, you'll see it's just kind of just a layer of connective tissue without a lot of integrity. So muscles can't really use that as a fulcrum or as a base by which they can contract. Other than we have all of the levator ani muscles as being a part of that. But then the other side of that is if you look at the way these muscles form this sling, is that they really do, at least anteriorly, have a very muscular attachment to them, or a bony attachment to them. Okay. So now we get to this level, and what we're really looking at, so if we think about what's over here, don't worry about all these little pieces over here. What we really want to just focus on is this piece, L4 and L5, which was the lumbosacral trunk, which is the continuation of parts of those ventral rami coming from L4, which is also part of the lumbar plexus, L5 that is not, but those four come down and they bring those axons, both sensory and motor axons, down and now join with S1 and then eventually S2 and S3. Forget S4, okay? So here's our sacrospinous ligament. Remember, from the inside, we're now defining this from the inside, sacrospinous ligament coming from the ischial spine to the inferior lateral angle of the sacrum. But now we have this huge conglomeration of nerves that are exiting through that greater sciatic notch, or foramen, because now it has a boundary to it. But think about it from that point of view. You also have piriformis going through here as well. So think about just the space that's occupied in there, specific to a muscle that can change its shape due to contraction. And then you have this large nerve in there, which is then the continuation of that going all the way down the posterior part of the leg. Now, this plexus is no different than the brachial plexus was. It's no different than the lumbar plexus was. It's all made up of ventral rami of those particular segments. And then those ventral rami are going to branch into anterior and posterior divisions. And all the anterior divisions are going to fuse together to be one nerve, and all the posterior divisions are going to fuse together to be another nerve. Okay? when we look at it kind of without the kind of the simple anatomy of it and look at it from the point of view of what does it look like specific to forming this sciatic nerve, is if we follow it back up, so here's L4 and L5, and here is that coming down, here's the lumbosacral trunk right here, adding to S1, S2, S3. When we look at it specific to the formation of the sciatic nerve, and we have a common peroneal or common fibular division and a tibial division, both of them start at L4, but the common fibular division doesn't have an S3 component. That's really the only difference. Tibial divisions L4 through S3, common fibular division L4 through S2. Okay? And again, we're not worried about coccygeal branches or any S4 or any of those kind of things. But ultimately, just looking at this table is just the ability to say, okay, at any given piece, anterior rami, ventral ramus, okay, here are the segmental components that are going to form the sciatic nerve. And again, we're just looking at sacral plexus, forget about the coccygeal side of that. And we've looked at sciatic nerve, superior inferior gluteal nerve, nerve to piriformis, nerve to quadratus femoris, nerve to obturator internus. And then we haven't looked at any of these other pieces. What we want to think about, though, is the pudendal nerve now, and really nerves to levator ani and coccygeus, because those are the nerves that give us sort of the motor control over our pelvic floor or pelvic diaphragm. Okay? If you look at the formation of the sciatic nerve, so we're inside again, looking and going out, so we would identify the sciatic nerve outside, but this sacrospinous ligament is kind of a landmark by which we can identify one of the primary nerves for the somatic innervation of the pelvic floor. And that's this nerve right here, which is the pudendal nerve. So coming off separate than the sciatic nerve, but coming off S2 and S3 and sweeping around, and then so coming out of the greater sciatic foramen, but then going back into the pelvis through the lesser sciatic foramen is this pudendal nerve. And it's setting right on top of that sacrospinous ligament. Once it gets back into the pelvis, then we're looking at structures of the perineum, sensory to genitals, muscular branches, da-da-da-da-da. Critical thing to think about it from a clinical point of view, if you have a bike seat that doesn't fit well and you're riding a lot, and all of a sudden your butt goes to sleep, your genitals start to lose sensation, it's all because the compression of that bike seat pushing on this nerve as it runs over that ligament and starts to change the way those axons can carry either the motor information out or the sensory information coming back in. So long distance bike riders that don't have a well-fitted seat can actually cause short-term and even in some extent long-term damage to sensation and muscular control of the pelvic diaphragm. Okay? Now, how would we see this in the cadaver? Well, that's a good question. Because ultimately, everything we've looked at is external. What I hope to be able to do is if we look at where we are right here. So here's the sacral promontory. And if we followed this around, this is our arcuate line right here. So this is the separation. We would be looking in here in the true pelvis. Out here is the false pelvis. So we really need to be able to look to that cadaver So let's go back up to this. So we're really looking at these nerves as they're emerging out of the anterior foramen of the sacrum, and then forming that sciatic nerve, and then ultimately exiting or trying to exit next to inferior to piriformis. So they're all going to be forming and kind of fusing on top of the coccygeus muscle, and then going between coccygeus and piriformis. So it's really somewhat obscured, just like the formation of the femoral nerve and obturator nerve, or the formation of the lumbar plexus is obscured because it's occurring within psoas major. Same thing goes here, is that a lot of that formation is now obscured by the fact that those pelvic floor muscles and piriformis are kind of sandwiching that nerve and their branching patterns between them. So hopefully what I will be able to do is to kind of free up one of these sides so that we can get a sense of piriformis and get a sense of coccygeus, and be able to see the relationship of those nerve branches coming in and ultimately fusing to form at least the sciatic nerve, or the majority of it, as it goes out. Can we then, will we be able to come into here and say, I can find the superior gluteal nerve and the inferior gluteal nerve? No, not from the inside. But it'd be nice if we could, but I don't have the time, and I don't have the want to bisect the pelvis to get that to show up, okay? Because that's really what it takes. Now, we've already talked about this a little bit, but what I wanted to do is show these images, because they're a little bit different than kind of that two-dimensional image of the bifurcation of the common iliac or the abdominal aorta when we look at it from a frontal point of view. So here we're looking kind of at a mid-sagittal point of view, and it just so happens it's male and female, and that doesn't really matter because we're not going to focus on that. But ultimately, and I'm going to focus on male because it's at the bottom instead of way up here. But here's our common iliac artery. Remember, that's just the bifurcation of that abdominal aorta right around that sacral promontory. If you look at these images, so here's the coccyx down here. This curvature right here is the sacrum. So we have S5, 4, 3, 2, 1. And so our sacral promontory, or where that lordotic curve for the lumbar vertebrae kind of stops, and now we have that large kyphotic curve, or that primary curvature, fetal curvature, in this direction, where kind of think about things coming straight down, and now there's this big bend. So it's kind of obscured. But once that happens, we have our common iliac artery, and as it comes down, it bifurcates into an external and an internal iliac artery. External just heads out, becomes a femoral artery, passing underneath the inguinal ligament. Internal iliac artery now has a relationship with the formation of the sacral plexus. Again, setting in there in that deep part of the pelvis, so we're in the, really at a level of, if this is the sacral promontory, here's our arcuate line. So again, we're in the true pelvis versus the false pelvis. False pelvis is going to be up here. This is going to be the inside of the ilium, or the pelvic bone, and is going to be primarily covered with iliacus muscle. Okay? But internally then we have, coming off of this internal iliac artery, superior and inferior gluteal arteries. Ultimately we have a number of other branches, and we're not going to get hung up on those. But I just want you to, we've seen them, we've seen their position externally. When we dissected, or you guys had the Japanese students dissect the gluteal region, remember that we had specific to above and below the piriformis, we had a neurovascular bundle, superior gluteal nerve and vessels. Superior gluteal nerve was innervating gluteus medius, minimus, TFL. Inferior gluteal nerves and vessels, inferior gluteal nerves innervating what? Gluteus maximus, okay? Might be on the test. Might. Okay? But what I hopefully am going to be able to show you is kind of that relationship from the inside that we saw on the outside, okay? Again, sort of the two-dimensional look of that. Here's the abdominal aorta bifurcating to common iliac, then bifurcating again to internal, external iliacs, ultimately becoming femoral vessels and or becoming muscles of the, or arteries of the gluteal region. Think about that. There is nothing of that internal iliac artery that extends past the pelvis. Everything specific to anything going on farther down the lower extremity is all a continuation of the external iliac artery. Whether it's the femoral artery that becomes the popliteal artery, becomes posterior tibial, anterior tibial, medial lateral plantar, dorsalis pedis, or whether it's the deep femoral branch that then just does the thigh. But all the lower extremity past the gluteal region is all branches of just that external iliac artery. Internal iliac artery branches are primarily for the pelvis and the perineum, with the exception of those gluteal branches that serve the gluteal region externally. Okay? That's the same thing. Okay, now, the last piece of this that I want to try to do, and again, it's going to be somewhat difficult, but what I want you to think about, though, is the relationship. If we had cut a coronal piece off those bodies and pulled it away, what we're looking at is here we're looking at the continuation of the sigmoid colon into the rectum, into the anus. So here we have basically the bottom end of our gut. But less of what I want you to think about is that, than what I want you to look at is specific to the relationship of this group of muscles called levator ani, and then its relationship to obturator internus. If we go back to that kind of that bowl picture, levator ani was that group of kind of horseshoe-shaped or horseshoe-oriented muscles that swept around that bottom part of the gut, around the rectum and around the anus. And part of the reason for that is that while there are some voluntary muscles, external anal sphincter, which is really just a typical sphincter that closes down, the other part of that has a big role in our fecal continence is really this group of muscles called levator ani. And again, want to show its relationship to obturator internus muscle. Okay? So, I'm not going to do these muscles. So these are the muscles of the pelvic floor, external pelvic floor, that are responsible for, in part for fecal and urinary continence, but also for sexual response. So two muscles that are critical for that. We're not going to dissect them, but I think you need to look at them in relationship to the external genitalia. These two muscles are these muscles that are running right alongside here, which are ischiocavernosus, and the one muscle that kind of encompasses here the root of the penis, but on this side kind of is on either side of the vestibule, which is really muscles that are lying internal to labia majora. And those two muscles, ischial-cavernosus and bulbospongiosus, are muscles that are critical for sexual response, sort of the somatic side of sexual response. Okay? And they're analogous in males and females. They both have the same kind of function in terms of allowing for a somatic response to something that is really can be, if we want to get just totally neuro about it, is just an autonomic response, but it's also can, if we want to get beyond that, becomes a very cognitive response. But they're the two muscles that allow for the somatic side of ejaculation or of orgasm, okay? But we're not going to dissect them, so we're not going to worry about them in the lab. What I do want you to know, though, is to look again at this levator ani group specific to, and again, male and female, but we're not worried about that, but kind of the relationship of if we're looking inferior, so we're looking from the bottom up, here's the coccyx, here's coccygeus muscle coming off of it. Okay, and you see it coming all the way over here to the inside of the ischial tuberosity. Okay? And then you have these muscles right here, these sling muscles or these horseshoe-shaped muscles. Iliococcygeus, pubococcygeus, and the one that's not on here is puborectalis, which would be more internal and wrapping right around here. Okay? So those three muscles, puborectalis, pubococcygeus, iliococcygeus, are the muscles that are listed as that levator ani group. Where's that picture? Oh, no. Oh, there it is. It's way down. No, all the way past it. So this is kind of what I want you to think about in terms of what that levator ani group of muscles is designed to do. So here we have the sigmoid colon coming into the rectum and then ultimately into the anal canal. Here what they have is they have this sling muscle, in this case it's puborectalis, coming off the pubic bone, sweeping around the rectum and coming back to the pubic bone, but it then is supported farther out by the other two muscles of levator ani. And if you look at how they do this, while we do have a specific anal sphincter, which can close off that external opening, the majority of that is the majority of fecal continence, of holding things above the sphincter muscle, is a function of this levator ani. And notice how it kind of slings behind posterior to the rectum. And as it pulls forward, as these muscles concentrically contract, they pull this forward, increasing the angle of going from the rectum to the anus. And that is not a pure sphincter muscle, and it's not closing anything off, but the increasing angle of this ultimately holds the fecal content above that. So it's not pressing on the sphincter and asking the sphincter to be more active. Okay? And so that's what I want, hopefully, be able to show you specifically on the cadaver, is the orientation of this levator ani. So the combination of those three muscles. So here again, here we're looking down in the bowl. Okay? So here's puborectalis coming off the pubic bone, and that's the one that was just shown in that other picture. Is it sweeps around and it's lying right on this posterior wall of the rectum and comes back and is attached to the pubic bone. Then lateral to that, then we have pubococcygeus, so it's coming all the way back. And so what's kind of, you can't really see here, but the tip of the coccyx bone is right underneath here. So from little lateral to puborectalis is pubococcygeus, so it's coming back to there. And then you have ileococcygeus coming there. So while the two pubococcygeus and ileococcygeus don't really support that sling part of it, they really are making sure that the pelvis and pulling of the coccygeal, that coccyx bone forward, helps to make sure that this area in here is narrowed as much as possible. Okay, again, the purpose of those muscles is not to act as a sphincter, but to act more as a blockade to kind of hold all the fecal contents above that, so it's not pressing on that sphincter and asking the sphincter to do it all. Okay? Are there any questions on that? Hopefully the dissection will come out well and we can see it. If it doesn't, it doesn't. So, okay? It's kind of a hard dissection to do without bisecting the pelvis, because you're kind of trying to dissect down in a little. I mean, the bowl is really about this big. It's not very big, you know, especially in a male. Females, it's a little bigger. Okay? So we can have birth of babies easier. Okay? Yes?
What time do you want to get lab?
I'd kind of like to, if we could get down there at 12:30 or so, a little bit earlier, give me, you know, and again, if you guys want to stay as long as you want, that's fine. I just really, my wife's got her other ladies meeting at the house tonight, so.
Are you going to be in the lab Sunday?
Not Sunday, no.
But we were able to.
Yeah, you should be able, so guys, again, you should be able to get in the lab anytime you want. Okay, your key cards are supposed to do that. I know there have been problems at times with one is you swipe the card, open the door, this alarm sounds. Security forgot to do that. That's a good thing. I need to call them and let them know that the lab is should still be open, because I'm sure they're working on Regis University schedules, not on Creighton schedules. So I will make sure I call security so that they have it on their list that door needs to be, the alarm needs to be turned off, and that the inside door should not be key locked. The inside door key locks. Okay? And so I will do that when I get back to my office before I go downstairs, to make sure that you guys have access throughout the entire week. Okay?
And then, did you guys just make the list of everything you've never?
It's not complete yet.
Okay.
So that's the other thing I want to do between now and I get down there, is try to make it as complete. And again, it's going to be complete from what I can think of in my mind in terms of what I've dissected and can show you. And will that change between then and this afternoon and tomorrow? Probably. A little bit. Not a lot. Might get, but in other words, I might be a little bit more aggressive of putting something on there and then not being able to show it to you and then deleting it. Okay?
So by Friday, then?
Yeah, for sure by
Okay.
Friday. Hopefully by this afternoon. Okay? Anything else? Okay? It's gorgeous outside though. Too bad you can't just roll the cadavers outside through that. Was that a little insensitive? Actually, you guys know that big fence over there? When we first brought cadavers in here, that fence was not there. And they told the neighbors, they actually, before we ever did that, they went to the neighbors along that north walkway and said, we're starting a PT program and we're going to be bringing cadavers in here. And we're going to unload them right here. Is that a problem? Is it a problem knowing there are human bodies in this building? Are there a problem with us unloading them? No. Until we brought the human bodies in and they saw them unloading them, the neighborhood went crazy. So then they built a fence. And now the neighborhood can't see it. No, it's still there, but the neighborhood can't see it. So it's kind of funny. You do everything you think you're gonna do, and then, oh, I mean, you meant real bodies. So, okay, any questions? Yes,
Are you gonna by any chance post like a practice?
yes, I will get a practice exam, lecture practice exam.
Okay.
Okay.
I just feel like this one's a little different.
It is, it's a little, because it's not so much musculoskeletal, it's not focused as much on what you guys might think about in terms of practice acts and things like that. So it becomes a little bit more general, okay? Anything else?
Is there an opportunity for extra credit after?
Oh, yeah.
Just in case.
Again, I don't want to make this a precedent, but yeah, I'm sure that if that, what I don't want to happen is saying, okay, I'm always going to have an extra credit question test of 10 points or so afterwards. So, yeah, if I don't work this hard on it, I always have that opportunity.
I think everybody's
So,
pretty much stays with
so.
Don't you worry.
But more than that, what I don't want, there's no way I can stop it, is I don't want the grapevine of information to your incoming underclassmen
No, we'll be scared.
saying, don't worry
No,
about
we're
it,
gonna
Cliff will give you an extra credit
No.
quiz
No.
if you screw it up.
No, that was
They
like
need to
a-
be as scared as we were coming into this.
That's it,
More
that's that
scared.
Jesuit way. Show that compassion for your,
No. Everybody has to have the same feeling.
It's still 60-40, you don't wanna switch it?
well, I don't want to be held to that because it will be to, when I think about it from a point of view of just a written test, 60% of material over just what we've covered is going to be really difficult to use. So it might, flush backwards to 50-50 or something like that. I mean, certainly there are going to be a lot of questions specific to, thorax and abdomen, okay? They're not going to be clinical kinds of questions where damage to this, to the celiac plexus would result in what? And we haven't talked about that, so that's really not, appropriate, but just the simple parts, where would you see the pancreatic vein? Where would you, or the splenic vein? Where would you, how do you form the, what's the difference between a hepatic, cystic, common bile duct? Those kinds of things, as opposed to something very clinically related as, so loss of cervical plexus, C1, C2, and C3, are you going to have difficulty with motor activation of suprahyoid muscles or infrahyoid muscles? The infrahyoid muscles. Suprahyoid muscles are by trigeminal and facial nerve. Okay? So that kind of thing, more for those. But for the viscera, no. Vestibular folds are involved in, of the larynx are involved in phonation, yes or no? No. They're involved in sensation for cough reflexes, that kind of thing, okay? So not the nerve-muscle relationship, nerve-muscle function relationship of the musculoskeletal system, okay? Anything else? Okay, guys, so I do have a request. I'm not really sure what I did, but I got several messages from somebody at Creighton saying, fill out this evaluation piece. And I think what it amounted to was that I was setting up that you guys had an opportunity to evaluate these classes.
Do it from Dee.
Yeah. Like on a daily basis.
I'll send them
Every
send them
day.
every 3 days. See it at like 3:30 in the morning.
Yeah.
I really want you to do it.
So I went through and I don't know what I did, but I did it. So apparently she was happy with it because I don't get any messages anymore. All I had to do was submit it. But if there's an evaluation, in any way, please let me know. Because, you know, it's a new class. It's always a struggle with a new class to say, am I giving too much? Am I giving too little? Is it organized, disorganized? How could I make it better? And that's really the big piece, is how could I make it better? Okay? So that next year's class, maybe we don't have as many kind of mistakes and starts and stops and pieces in there that got lost. That it can be a bit smoother running class. And that's really what I want out of it, is how to make it a smoother running class. Okay? So if there's that opportunity for you guys, you know, we used to make, I don't know what Creighton does, but we used to make our students sit in class and fill out scantrons of evaluations. Got 100% compliance. Then it went to being online, and with no penalty for not doing it. And all of a sudden, instead of 100% compliance on evaluations, you start getting 30%. Which in reality, when you look at survey types of things, if you get 30 to 40% compliance in that, you're doing pretty good actually. Which is kind of sad, but you know, but we're not allowed to use evaluations as kind of a gatekeeper of releasing grades. So I know some schools do, but Regis won't let us do that. So, and I don't know what Creighton's policies are, but if you have the opportunity to do it, you know, please do that. I have really thin skin, so you know, don't whip me too hard.
Yeah.
Okay? All right, guys. So I will go work on the list, see how far I get with it, and bring what I have down, and then I'll see you down in the lab like 12:30ish or so. Is that okay? Anything else?
The list from the very first one, the first lab article, like saved that you could
Oh, yeah.
throw up and
Yeah.
or bring down today.
Yeah.
Okay.
Yeah.
Because we have the second one, it's online, so going back to the very first one.
Okay. Yeah.
Serious review on that. So.
Sure.
Thank you.
Yeah. You want me to just put it online, or do you want me to bring a hard copy down?
Today. Yeah.
Need to help? Okay.
Yeah. I do have it. I was gonna say, I have mine. Oh, can I just picture of just the. You have it. Yeah. Oh.